Hey everybody, what's going on? Gestalt Education back for another year. We're going to start this year off right with letting you save some money. So two of our favorite people are the Core 360 belt and human locomotion, which is Dr. Thomas Shouts. So don't forget, if you use the code Gestalt for the Core 360 belt, you get $5 off all belts except for the Ohm Track sensors. So Brett, what are some of the Michaud's favorite, some of your favorite Michaud gadgets?
Well, I mean, he's got a trunk full of gadgets, but I think my favorite one definitely would be we use the Toe Pro quite a bit. The Toe Pro, and then I think the Varus and Valgus Post have really given people like a nice option if they're not want to take that leap into like a customized orthotic to kind of, a good option for the patient, but also to let them kind of like, bring the power back to the clinician to kind of decide where to post it. And so I think those are the two probably ones of Tom's stuff that I love. And of course, I can't get enough of his human locomotion. I mean, the book is still to this day pure insanity. So
beautiful. Yeah. Don't forget to use the code Gestalt on both those, the Core 360 belt and then also human locomotion. Links are in all of our podcasts. And we hope you guys like today's episode. All right, everyone. Welcome to another episode of the Gestalt Education Show. We are back for round two with the world's expert on the ACL. What'd you say? 2 fingers lengths, two joint lengths of a finger
of your pinky.
That's right. So in episode 1, Brett, we covered basically the assessment piece. We talked about the problem. We talked about factors that predispose you to it, all that kind of stuff. But then for part 2, we want to kind of get into the nitty gritty of. I kind of leaned into it initially on. How would you actually build a prevention program from the top up? You've been in these amazing settings, whether it be the Mayo Clinic, now you're at Marshall, you've been at all these awesome universities. So Tim, take us through like how you would actually implement a prevention program in a university setting or even like a high school setting, maybe from the strength conditioning to the rehab, all that type of thing.
Well, the first thing you have to do is you have to get all the stakeholders involved. So a big problem is usually when they pull the ACL guy in is when they've had a huge slew of ACL injuries. Happened with our Boone County cohort, or whether it be Galesburg High School where they had 4 of their 5 starters rupture their ACLs and they're ready to hang the girls' basketball coach by his toes. That's not really the time to do it. The time to do it is as early as possible with all the stakeholders involved. So you obviously need the coaches on board. Very often, the way we get involved is the assistant coach level, someone who has more time and energy. Very often, it's someone who's suffered an ACL already. And then you get them to help you get the coaching staff. And from there, the coaching staff. So when we look at all these factors, and my graduate student, Dai Sugimoto, did a lot of this in his thesis. There's compliance with training, and that's troublesome because compliance tends to be really low. And coaches tend to be the least compliant with it. And then there's adherence, and that's about the athlete. That's the person doing it. You also need adherence to be high. If coaches don't buy in and they're not compliant, then adherence is going to be low. So you got to get the coaches on board, and then the whole athletic staff, including the sports medicine team, has to be involved. And that's the first thing I did when I went to Marshall University is met with the athletic training staff and coaching staff and got everybody on the same page. And that's key. So then from there, you talk about what the needs are across the teams, across the athletic department, and then you develop very targeted training that is going to be useful for their sport. Something that's designed to be preferably pre-practice, pre-game type of intervention that's going to be easy, relatively easy to institute. So you don't want to invest more than 20, 25 minutes prior to practice, and something that is going to directly target those neuromotor imbalances that lead into this ACL injury mechanism: inward collapse of hip and knee, anterior translation of the tibia, internal rotation. So what we know is the neuromuscular imbalances that lead into this are ligament dominance, leg dominance, quadriceps dominance, and trunk dominance. So within a sport, design around those targeted interventions. And again, what we're going to do is we're going to incorporate simple low-grade plyometrics that develop. Everything is phased. We always have a minimum of 4 to 5 phases that are going to take you from starting out at a simple level, strengthening, and then into 3-dimensional, foot-based, greater control of the trunk and core, greater proprioception, balance, strength, especially of the posterior kinetic chain, to prepare that athlete directly for their sport, and preferably make them a better athlete in that sport too. I think that's a critical part of it, that they see, the whole system sees, hey, these guys are better athletes with this training. And you can demonstrate it. We've demonstrated it repeatedly in multiple studies.
And we did that. This is how old I am, Tim. We, in our local high school, I was going up to the high school, and we were doing your sports metric program. That was you and I think Frank Noyes were together at that time and doing that. And it was a lot of jumping. I think you guys were, and you had all the data to show it. So how we're able to sell it with our basketball team was they had 2 ACL tears the previous year, and we're basically like, I mean, look at this data. I mean, the data even back then was just insane. Has the program evolved and changed since that original rollout 20 years ago? Or
it has, definitely. And we were criticized because it was too much. So I was a competitive power lifter, and I didn't mind high volume and high intensity training.
In fact, you liked it.
and I still do, actually, at this advanced age. And so, people said, well, that's too much. It's too much time. It's, no one's going to do this. And yes, we evolved it over time. If you look at our most recent studies in AJSM, which were school-based, team-based, multiple sport-based, pre-practice interventions, we went from an hour and a half down to 15 to 20 minutes. Again, to what? Enhance compliance and enhance adherence, because those really are we know, we have the data that shows that with these interventions, you can reduce the risk of all ACL injuries by 50%, non-contact ACL injuries, especially in females, by 2/3. But if people aren't compliant with it or adherent to it, it's not going to be effective. So yes, it's changed significantly over the years and working with different teams and in different environments.
Well, let's just kind of go through the continuum of like kind of that hybrid from the rehab to the strengthening phase. So, I mean, over the years, we've had pioneers like Vladimir Yanda who've shown us glute bridging, clam exercises, the kind of those low-level table exercises. Do you still have a role for those? Is that still being utilized in your model?
Yes, absolutely. Now, again, that's more return to sport type training. Someone who's had a prior ACL injury. Now, again, that's really my current passion, because when we followed out these cohorts that first we employed these cohorts to identify athletes at risk. Then we did interventions to reduce risk, but some kids, especially in the control groups, still had injuries. And then we kept following these same cohorts over many years. And what we found out was those kids had an ACL injury, had significantly higher risk of a second ACL injury. So if you're a young athlete going back to the same level of sport, your risk of having a second ACL rupture is somewhere between a quarter and a third. I mean, think about that.
That's insane.
It's way, way higher than someone who hasn't had an ACL injury previously. It's unacceptably high, and that's really my passion, my team's passion now, to figure out who's at risk of those second injuries, what are the neuromotor profiles that lead into this much, much greater risk, and then instituting targeted interventions that decrease that relative risk. So when I was at Mayo, we did a study where we showed if you're a female athlete, soccer player, going back to the same level of soccer, your risk of a second ACL tear, very often on the contralateral side, the unreconstructed side, is 35%.
Wow.
I mean,
it's just insane.
It's just unacceptably high.
So then, okay, I like to hear you're a power lifter. That's fun. So, so if we just take a back squat or we take a deadlift, does that have an important role in ACL tear prevention?
Yes. Again, strengthening posterior chain definitely has
no matter how you do it.
Definitely has a role. Okay. Again, that's strengthening your base, but then taking that to a neuromuscular, neuromotor level. So make sure that you're not only increasing strength, but increasing activation during sports movements.
Right. The kind of the latest craze in the last 5 years has been BFR training. What's your take on that?
I think most of the data shows in an injured individual that's going to enhance return, especially of those quadriceps deficits that you get post ACL injury and post ACL reconstruction. I think BFR is a valid adjunct to return to sport training.
And what do you like for single limb training in the weight room setting? What are some, we kind of talked about some double limb stuff with the squat, obviously in the deadlift. What do you like for single limb?
I really like single leg Romanian deadlifts with weights, right. Moving the weight hand to hand, but then progressing that again, primarily it's a nice exercise because it's strength combined with balance, but then progressing that into single leg, multi-dimensional hops, introducing balls, introducing perturbations.
What about what are obviously in our area? I don't know what it is here. A lot of the orthos are using Dartfish and other programs. Are you a proponent of that, or what is the technology that you like in this return to play?
Post ACL.
I would say all of it. I think you use as much. It's not technology for technology's sake. It's technology as a tool for the athlete's sake. So yes, video, whether that be Dartfish or Trazer or any of these companies that will get 2 and 3D video to you that you can use for active dynamic feedback for athletes. Force plates are very useful to monitor the relative force, because especially in that reconstructed athlete, what they're going to do is they're going to underload the reconstructed side and they're going to overload the unreconstructed side, and that's across the board. You see that in anything that they're going to do, and you want to make sure that they're equally the problem with. So the way I look at an ACL injury is it's more than structural. So you've got this 2 first digits of your pinky, that's the ACL, and it's a highly elastomeric tissue. It's really strong and elastic. So it basically can control the force up to, you're talking about between 1,800 and 2,200 newtons, which is 550 pounds that it takes to rip your ACL apart. yes, it's a structural tissue, but it's also highly innervated. It has all 5 types of mechanoreceptors. And the way I look at it is when you rupture this ACL and you pull it apart and you turn it into mop ends, is you're opening up a circuit. So you've got these neural circuits, afferent to the spinal cord, efferent feedback. And so, for example, if you, take a decerebrate cat, or you take any individual and you pull on their ACL, you pull it forward, what happens is afferent, efferent, you turn on your hammies to pull the tibia back to take stress off the ACL. And you lose that neural connection. And what you have is with this, now that you've blown this circuit wide open, you have an open circuit, and apparently it goes to the spinal cord and says, that's an on signal. An open circuit is, we have an on signal, and then the spinal level inhibitory neurons are turned on, and then they turn off the efferents. And that's why you have this immediate rapid shrinkage of the quads on that side. It says, we've got an on signal. These muscles are all turned on. We need to turn them off. And what rehab professionals are doing in the meantime is adapting and developing parallel circuits through the fascia, through the skin, through the musculature to develop new sensation of the center of that knee joint. Again, the problem is that takes a lot of time. If you look at any simple measure of joint kinesthesia, joint proprioception, that doesn't come down to baseline not significantly different from one side versus the other, or from some control population, until around 2 years out, which is a crazy amount of time, right? But that's what it takes. It's a very slow process. And we don't know if neural reconnections, whether that be through a repair or a reconstruction or any healing that occurs, if that circuit is ever renewed, there's very little data out there to say one way or the other. In dog studies back in the 80s, there were some indications that there was some neural reingrowth into an ACL reconstruction. There was a human study done in Norway where a guy was 18 months out. He couldn't handle the long, dark Norwegian winter, offed himself. They actually sent his knee over the United States, looked for neural connections in nerve endings in the ACL, and found nothing 18 months out. So that even if you did have neural reingrowth into, say, a repair of the ACL, it's probably not calibrated to the level that it would need to be to really sense and to set up those afferent, efferent feedback loops in a way that were going to be as effective as they were in the native ACL.
So that's why the re-tear rates, that's one of the mechanisms of...
One of the reasons, because you just don't sense that joint as well. And again, the problem is, so what you see on that, with that, is you develop a stiffening strategy. What individuals do when they don't sense, and we've done several studies on this. Basically, if you look at a measure of joint coordination across the lower extremity joints, or force profiles, muscular contributions across the lower extremity joint, what you see is a stiffening strategy. When you don't sense a joint very well, you lock down its degrees of freedom of motion, you stiffen it. So what happens is, on the involved side, you stiffen up your knee. It doesn't go through as much of a range of motion. You lock down its degrees of freedom. Now, at the same time, you don't sense it. You're underloading it by overloading the opposite side. So here's the problem. You still have high force on the involved side, because even though you're overloading the opposite, the contralateral side, because the joint's stiff, you still got a lot of force going through it. That doesn't go down. But the force on the opposite side goes significantly up. And we've seen this in just about every experimental paradigm that we've developed to look at it. It goes way up on the other side. So the involved side is at risk because it's stiff and there's a lot of force going through the joint. But the other side, the risk is even to a greater extent. And especially in athletes that are prone to these four neuromuscular imbalances that I talked about: ligament dominance, quadriceps dominance, leg dominance, and trunk dominance, that they really increase risk on the uninvolved side. And here's the problem. So when you open up this circuit on the one side, the involved side, the body wants efficiency and economy. Okay, economy of movement is what moves the body forward, and the body wants to be economical. You need to be symmetric, one side versus the other, whether that's walking, running, jumping. You need to be symmetric. Well, this circuit is open, and as we said, this takes a long time, about 2 years to come back, not significantly different from baseline. So what does the body do to create symmetry? It changes the nature of the wiring on the uninvolved side. So now you're compromised on your uninvolved side as well to get greater symmetry with your involved side. And that's a lot of what people miss. Is it is at least as important to be training that uninvolved side as it is in training the involved side, especially if you have those high-risk athletes with those underlying imbalances very often that led to that first injury. You need to be focusing just as well, if not more, on the contralateral side.
Well, I think that could be very motivating too, because as you're kind of coming back from your surgical thing, you can be, doing a lot of work on the contralateral limb. And I think that actually would be a perfect time to start working on that, probably.
Yes, absolutely. And that's the thing. We need to have more in our return to sport protocols than just measures of symmetry, because you may be bringing your involved side up to symmetrical with your uninvolved side, but that's not good enough because your control you're using is compromised. It's not the same as it was before.
So that takes me to, sorry to interrupt,
No
but
worries.
to the next point of, is an isometric quad strengthening versus hamstring strengthening enough for a return to play criteria? I know that they're never used in isolation, but that's another thing that's added onto the criteria.
Well, certainly not. I think, again, isometric strength is important. And early on, that's what you're going to use. But again, even the strengthening, you need to put in a neuromotor component. So go to an isokinetic, go to a 60 degrees per second, then 120, eventually move up to a 300 or 360 degrees per second to check that neural component. Now, again, your quad ham ratios are going to be totally different. So relatively slow speed like 60, you want a near 100% ham to quad, sort of like an isometric. But when you go up to a really high speed, like 300 degrees per second, 60 to 70% ham to quad is good enough, because again, there's a neural component involved of turning over, going from kicking out to pulling the tibia back again.
This is so refreshing. I mean, because usually you don't hear people in the research world talking about the importance of the sensory system in performance or in, injury or anything like that. So, I mean, I think that is very noble of you to point that out. I always quote the paper by Hodges and Tucker. They talk about a protective pattern, like after you have any kind of pain syndrome, how your brain almost subcortically or subconsciously changes the strategy around whatever joint we're talking about. Yeah. And That might also be another mechanism why there's a 10% re-tear rate, in that first year, because they're told to go play because it's been 8 months, but they still are holding on to that protective pattern. And now I mean, to my own ignorance, I didn't even think about the contralateral limb, but now I will definitely start considering that. That is insane.
Well, the vogue now is to look at brain changes after ACL injury. And yes, does the brain change after an insult like an ACL injury and then another big insult like an ACL reconstruction? Absolutely. You see brainwave changes because your brain certainly knows at afferent, efferent spinal level, you have an open circuit. Your brain is well aware of that. And people are focusing now on looking at brain issues. However, once you get back into sport, the corrections have to be subcortical, right?
Yeah.
Because an ACL injury happens in 30 to 50 milliseconds. You don't have time for the afferent signal to reach up to the brain and react to it. So there has to be changes at the afferent, efferent spinal level for it to be effective to reduce the risk of a second ACL tear, whether that be on the involved or the contralateral limb.
I mean, the obvious, I guess, area of the brain would be like the somatosensory cortex. But do you think like the frontal cortex and other areas?
There are other areas that, yes, adapt. I mean, this is when you think about it, it's a significant injury and your brain has to be aware that it's there. And again, as we said, as rehab professionals, what you guys are doing is developing parallel circuits, and the brain has to sense that and react to it. It has to.
Yeah, there's an old saying too, the brain never forgets. So like once you've been injured, and I think that's one reason why like Achilles rupture, ACL tears, that when the athlete comes back, man, do they struggle, because, there's famous, you had Adrian Peterson who came back in 6 months, and then you had Derrick Rose, who 3 years later, they're telling him to go out and he doesn't want to go out. So I think there's a whole mental component, as you're well aware of this injury.
The psychology of it is some of the best predictors. So we use Kate Webster and Julian Feller's ACL RSI, their ACL Return to Sport Index, and we demonstrated in a large cohort of athletes that one of the best predictors for both returning to sport and, believe it or not, risk of a second ACL injury is ACL RSI score of 76 points out of 100 or better.
Is that basically anxiety around?
Anxiety, fear, confidence, all of those different modules of psychological input.
It's kind of cheesy, but one thing we do with our athletes is after that injury, we have a conversation because, it's all gloom and doom early on. You've been in the orthopedist, your whole livelihood has been turned upside down. Scholarship's gone, maybe gone. We say, let's use this injury as a catalyst. So, from this day moving forward, this is going to make you a better basketball player. Like this, do you think that like self-talk is I think it's absolutely. No one ever talks about that.
It's absolutely critical.
Yeah, I think so too.
Yes, you are right on. Decreasing fear, anxiety, increasing confidence within also an envelope of knowledge that I am at increased risk of tearing again, without increasing that anxiety and fear component.
So you had a paper that came out that said that, and you corrected us before we started, that maybe it would be beneficial to wait longer periods of time before you come back. We had Dr. Andrews on the podcast. He basically bold-faced told us, he said, ACL tears, you have to basically wait. You should wait a year to get them back because the rates of re-tear rate, I mean, it's so statistically significant. It's crazy. So you can talk about how you got framed into the 2-year mark, but what do you think? Do you agree with that or?
So again, that was a bit of a tongue-in-cheek article. So what I was saying is, if you look at any measures, whether biologic measures like healing of a hamstring graft, it takes about 2 years for it to religamentize. If you look at measures of knee joint kinesthesia, proprioception, about 2 years to come back down to baseline. If you look at bone bruising, it can take 18 to 24 months to heal bone bruises. If you look at a hot joint with a PET scan, I mean, they remain hot for 18 to 24 months out. So any of these factors that you look at, we realize most people aren't going to wait 2 years. Again, a high school kid, that's, pretty much their high school career. That's why, really importantly, that we use objective criteria to constantly and longitudinally assess these athletes, give them feedback, and progress them on. Now, again, so at an AOSSM meeting a couple years ago, some people got myself and Chad Lavender together, who's the proponent of the fertilized ACL. He's the developer of the fertilized ACL, and he's getting people back very early after months. And the question is, they actually brought us together because they wanted me to just openly attack this guy who's now become actually a colleague and a good friend of mine, because we agreed on like 19 points out of 20. We just have to figure out, what do we use to progress these people back to where they are safe when they return. And currently that's unknown. Kate Webster and I did a series of meta-analyses where we showed that current return to sport protocols just aren't reliable or valid for telling us when that is. And we got a lot of work to do to figure out what that is, because seriously, if you're just going to use time, you better wait at least a year and maybe 2.
Tim, if you tore your ACL today, can you talk about the repair that you would? Well, first of all, I'd say, would you repair it? Because the cool thing to say is now that you wouldn't repair it. So would you repair it? If you were going to repair it, what would be the style that you would be using? What are your thoughts on that?
Well, if I'm being at my place in the world, which is a ever fast aging power lifter, no, I would not reconstruct. I would not reconstruct my ACL. And now, what we know, and we recently I published this paper also with Chad Lavender and Kate Webster, where we did this, revisit the biomechanical rule of thirds of an ACL. So a third of people, once they tear their ACL, they have giving ways with activities of daily living. Therefore, they need to have their ACL reconstructed. Another third of people can do activities of daily living without an ACL. So if all they want to do is activities of daily living, they don't need an ACL reconstruction. Then there's the final third of people actually can function at a very high level without an ACL. So I think it's worthwhile to do a time of trial of function. It's okay. I think it's reasonable to let the joint calm down anyway. Do your prehab, see how well, and prehab is gonna benefit your reconstruction anyway, and then give it a trial of function and see how you do. So yes, I think about a third of people don't need an ACL reconstruction. Now, if you're young, physically active, want to go back to the full level of sport, and you can't quite function without that ACL, now surgeons will tell you if you go back to full sport at a high level and really test that knee without an ACL, you're going to end up tearing your meniscus. There's some data to support that. However, I do think there is a contingent, about a third, that can function well without one. So what do the other 2/3 do? I think if I'm a young athlete, I do my prehab, I do my trial of function, and I still don't feel that I'm going to be one of those people that can function well without an ACL. I personally would recommend a quadriceps tendon graft. Bone tendon bone, patella, the bone tendon bone, the BTB graft is a good graft. You don't do that, say, if you're going to be a wrestler or someone has to be on their knee a lot, because kneeling is going to give you your problems. The one thing I will advocate against is a medial hamstring graft, because almost everything we've been talking about, hamstring is an agonist of the ACL, rotation of that tibia, your medial hamstrings control all that. Not only do they need the strength, they need the exquisite afferent, efferent control of that joint. And I highly recommend, especially in young female athletes, of getting a medial hamstring graft. So my graft of choice for a young active athlete is a quadriceps tendon graft. The surgeon can take pretty much any amount of that tendon that they want, and it's got about 20% more collagen than the patellar tendon does. And so if anything, you can err on too much of the putting too much of the quadricep tendon to religament ties into your ACL ligament. So quad tendon graft is what I would advocate.
There's anecdotal studies showing that sometimes the two ends on an ACL tear can re-find each other over time.
Yeah.
We see that like in Achilles rupture. If we boot them in plantar flexion, then since you're the expert in the world in ACL, when does that happen? How do you create the environment for that to happen?
See, the problem is that your ACL stumps, these rags that are mop ends that are left after, if you have a full rupture, full mid-substance rupture, because you're in the synovium has proteins that tend to block healing, and you don't have an active blood supply into that synovium to bring healing growth factors into the equation. However, lots of ACLs are not complete ruptures. There's been, in recent months, actually, there's been this advocates for the ACL can heal itself. So first, when they reported this data, they said, and this is Scandinavian data and Aussie data together, they said, 30% of these people will heal. Now that would hook up with our rule of thirds, right? Whether those are the same thirds, we don't know. But that was in a cohort that ended up going on to mostly reconstruction. And then they said, well, those that we watched longer that didn't go on to ACL reconstruction, about half healed. Now, what healing is what they're terming, this group in Scandinavia is terming healing is a black continuity of what looks to be ACL structure on an MRI. So then they said, well, we did this cross-bracing study where they actually braced them. And this is problematic in itself. They do allow some weight bearing, but the limb is braced, so it's relatively immobile. Now that can wreak havoc on a joint. I mean, we know immobilization can lead to significant osteoarthritis in a joint. So, and they don't have that data downstream of how arthritic these people would be. But they claimed in this cross-bracing protocol, they could get 90% healing, which is a continuity of this black mass of where the ACL was. Now, there's various things going on here. Sometimes the stump of the ACL, very often, it'll scar down to the PCL. Sometimes it will, if there's, very often these are not complete mid-substance ruptures, so they might be very proximal tears and have some bone with it, and that might heal down to other structures. So So the problem is this definition, or this thing we call healing. What is that? Is that a functional structure?
Right.
We don't know. What it looks like is a continuous black mass of fibers between your tibia and femur.
Sure.
We don't know how functional that is. So yes, it's very much in vogue to say, hey man, we don't need an ACL reconstruction anymore. Every 90% are going to heal up. I would call that the 90% number highly unlikely.
Right.
The 50% number unlikely. The 30% number closer to reality. Again, do we know what that healing means or how functional it is? We don't.
Right. On the rehab side of things, or the training side, you've talked about balance, dynamic balance. Are we talking about purely like land-based, or is there a place for like wobble boards, rocker boards? Are you a proponent of that or not really?
Absolutely.
Yeah.
I think we use all of the tools at our disposal. And I don't think one is, say, better than the other. Use it in a progression. Again, I think just single foot balance to start out with, introduce air cushion, go to a wobble board, then go to dynamic hopping plyometrics in a chaotic environment with balls and perturbations.
Right. Perfect.
That's beautiful.
What do you think as far as, to backtrack just a little bit? So now you're at Marshall University, right? Yeah. So a guy tears or a girl tears their ACL now. Would you potentially think they may be in that third, or is your thought they're performing at such a high level that we should surgically repair them? Or I know how it is in those worlds. I mean, you have the team doctor, you're having to navigate a bunch of different.
Very tough. I'd say the gold standard still is, if you're a high level athlete, to reconstruct your ACL. Again, the main surgeon I'm working with is Chad Lavender. He's going to do a fertilized ACL. And what he has is, he basically does an all inside quadriceps tendon technique. He adds 2 biologics. He adds bone marrow aspirate concentrate and demineralized bone matrix into a putty into the bone to enhance bone corporation of the graft, all inside. And he adds an internal brace to protect that construct over time. And
you're gonna break your leg before you tear your ACL.
He actually had someone who had a contact knee dislocation. The MCL, PCL, and LCL were all out, and his ACL remained intact, the graft, believe it or not. Wow. So, and these kids are coming back really early. The question is that okay? We don't know yet. Now, Kate Webster and Julian Feller, they're based out of Melbourne, Australia, collaborators of ours, and they do huge, that group does 500 plus ACL reconstructions a year easy, because down in Aussie Rules football pops ACLs they do these speckies, get their trunks perturbed, end up sideways, landing on one leg and on a flat foot and rupture their ACLs. And they looked at a cohort that was returned at basically 8 to 9 months versus one that they made wait a whole year, and there was no difference in re-tear rate. Huh. So the time delaying out a year, as Andrews advocates in their cohort, didn't matter.
Right.
So we just need to follow the evidence. We need to keep doing the randomized controlled trials, take this out to a level. And even if some randomized controlled trials, we're writing an editorial on this now. Sometimes it's unethical to do a randomized controlled trial because you're certain what you're doing is better. And so what we have to figure out is whether it be an RCT or whether it be a longitudinal cohort study, figure out what is best for these athletes. What's going to get them back early at a higher level, at as high as level as possible, safely. And that's where we all need to end up. And that's where we're working toward to hopefully where we'll end up soon.
Is there any, does the data say anything about an allograft? Or is allografts basically cliche at this point? Are those out of it? If we're all autografts? Or
allografts. So in young, physically active athletes who are really going to test that graft, no allograft. Their rupture rate is significantly higher. We're talking triple, quadruple. Now, in an older person who wants to go back to who is going to have giving ways without an ACL during activities of daily living, someone who wants to get back to golf or maybe even tennis, an allograft is certainly reasonable, but that needs to be someone 25 plus with lower level demand on the knee joint.
Sure.
Was it you that did the research, Tim, on the anterior reach, like that found a 4 centimeter difference from side to side? Because what was amazing was you guys found it, and then another group that I think used the Y balance device literally came up with the exact same number, which was 4 centimeters.
This is absolutely critical because that's consilience of data. That's when disparate data sets from different labs come to the exact same conclusion. And you're absolutely right. That's the data you trust. Absolutely.
So you like that as another, like the simple anterior reach, is there a difference? Do you like the Y balance? Is that?
Absolutely. Any tools to measure balance, proprioception, neuromotor control are useful. Use them.
Right. Perfect.
Beautiful. And then maybe just to finish it up, I know we kind of talked about biologics with doing these kind of fertilized ACLs. Do you concern yourself with biologics when returning to sport? Is there a place for it? Is that just maybe for the pain mechanisms? Talk through that.
Well, pain, healing, neural input, we don't know the role yet. The data out there is equivocal. And, things like PRP, most studies show PRP is being ineffective, but for PRP injections, for example, in tennis elbow, in randomized controlled trials have demonstrated to be efficacious. So we don't know yet. Those biologics, as long as they come from that individual themselves, are not FDA regulated. They may be oversold at this point, but we need to keep trying them to see what potential they have to enhance healing, but especially that neural reingrowth and potential healing that we've been talking about. That's critical.
Because George Paletta, who we recently just had on, he sees a huge role, for example, PRP for anti-inflammatory. He thinks that, versus using cortisone, it seems like maybe you're having a less destructive effect on the tendons and those types of things.
The good thing is because it's basically concentrated cells from the patient's own body, there shouldn't be, again, that's why it's not FDA regulated. There shouldn't be any negative side.
You're only out the money if it doesn't. Yeah, right.
Exactly.
Certainly safer than our current vaccinations that we have for some diseases I won't talk about.
Way to go there, baby. Yeah. I love it. Well, what about maybe if we could just finish up, we kind of talked about with our last guest about turf versus natural grass. You kind of talked about it. That was kind of your entry point. What about the new style of turf?
The new style of turf. This is data. This paper is actually a little bit old. This came out when I was leading the group at Ohio State, that was around 2015, and that came from the NFL physicians, and they did a study which was published in AJSM, which said your risk of an ACL tear was more than 60% higher on the new rubberized turfs than they were on natural grass. And your risk of a high ankle sprain was about 35% higher. Now, on the flip side, again, you see Kyler Murray the other day on this new, the whatever they call this new grass that waters itself. Mm-hmm. He had a classic dynamic valgus ACL on grass, but in 2015, that version of that turf versus regular old natural grass, because, you know, that it's assumed that stickier surface that holds your foot, and you have a higher chance of landing flat-footed, as we discussed on that increased risk of 60% or so. 62%, I think, was the number in the paper.
It's just crazy. We talked about with Dr. Krimchak too. And his whole point was just be honest about it. You know, stop trying to hide the data. It's out there.
Yeah.
We kind of know, and just be honest with what we know. It's kind of like our predisposition for ACL ruptures. There seems to be a female disposition with hormone changes. We stop trying to hide it and let's start talking about it.
Yes, it's a factor.
Yeah.
Whether we like it or not.
That's exactly right. I have to give you a little bit of a plug on you're a great Twitter follow, because you post a lot of this stuff, and you actually have been reposting every ACL rupture in the NFL this year. And I was just looking up to what we're at, and we're at 41 in the NFL this year.
41 in the NFL.
So it's still an epidemic. I mean, it is in its.
We will end up in the usual range of around 50-ish. Yep.
I got a fun game to finish. What has been your most fascinating ACL tear? Mine's Willis McGahee. Do you remember that injury? How horrific that one was? And he made it back and still had a great career. What is the one, after, I'm sure you've seen them all, what is the one that it was the most fascinating to you?
So do you remember Shea Rao from UConn? So she won multiple national titles, was a guard at UConn. And she had, well, I was lecturing to a group of orthopedic surgeons out in Vail, and I presented data. I said, this is her third ACL rupture and reconstruction, and she went on to 5. And a surgeon in the back raised his hand and said, "Hewitt, you're wrong." And, you know, going along with my twit personality, I said, that's not possible. Hewitt is never wrong. And his response is, in this case, you are, because I just reconstructed her a 6th time. If you can imagine, 6 ACL ruptures and reconstructions, and she still did that. I can't even imagine that. And we still see these in these kids that are going back. I mean, that first day in my lab at one point, I had 6 research associates in my lab that had 2 ACL reconstructions. Either most of them were bilateral, but some were the graft. And I'll tell you that one time is devastating. Very often when you go back, it's usually early in the next season when you go back and you tear again. That second tear is so physically, mentally, emotionally debilitating that not only do you want to get into the field to figure out why that happened to you, you want to do whatever you can to make sure it doesn't happen to you or anyone else again, because it's just so devastating. But 6 is unimaginable.
That's insane. I mean, for me, it's the Derrick Rose, Adrian Peterson, because they happened relatively around the same time. So
Adrian Peterson is a little off. Most people quote that as 6 months. It's actually 8 months to the day that Adrian Peterson came down. So he wasn't super early.
Sure. I think the fact that he broke the
he was like a yard or 2 away from breaking a single.
That I think is the crazy.
Well, that, and I mean, I knew the people that rehabbed him, and they basically said the dude ate pizza and, took naps. He, whereas somebody like Joey Burrow, who's like so conscientious. The difference, though, is when you think about a quarterback does a choreographed move. Right. So that should be easier. He knows where his feet are going to be going, and 80% of the time. But someone like a running back, because most running backs in the NFL who've ruptured their ACL will tell their colleague who's torn his ACL, you're not going to be the same the first year. Wait till your second year, mid second year back, your knee's going to start feeling normal again. And again, proprioceptors and developing those parallel circuits are absolutely crucial.
I think this is such a good conversation, Brett, because one of the big tenets of what we preach and, with Gestalt education, it's all about integration. So integration of multiple different facets. And we talk about sensory and motor integration all the time. That's a major tenet of DNS. And so hearing it reflect itself in the research is so awesome because it just kind of recertifies why we're doing what we're doing, why we're getting good results with some of the things we're doing.
Exactly. Again, I was lucky enough in the publications, most cited ACL injury research in the world. That's very cool. However, if people aren't using it, if clinicians like you aren't using it, it's absolutely meaningless.
Right.
That's what I've tried to do in my career is try to help you guys translate it out onto the field and onto the court.
Yeah. Well, what about, what's next for you? What's next for you? How about that as far as the research world goes? And then maybe what's next for ACL?
Again, using the latest in structural, biological, graft enhancements to come together so that neural reingrowth happens as early as possible to enhance motor control, proprioception, to bring these athletes back as fast, as strong, and as safely as we possibly can. And that is my absolute quest for the next remainder of my career.
Beautiful.
What a superstar.
Absolutely.
Thank you so
Man,
much.
We crushed all of it. That was so good.
Yeah.
Man, we're appreciative of all the work that you do, and keep pumping it out for us, please.
Trust me, we're reading your research. You just keep
just love it.
If you guys are interested in the research, I'll put your link on your PubMed, but it's in PubMed it's Hewett, Hewitt.
Yep, T-E Hewitt. 2 E's and 2 T's. Everybody spells it with an I on the end. It's 2 E's and 2 T's.
Beautiful. And then I'll link your Twitter on here too, because it's worth it to.
Yeah, it's a little bit of comedy thrown in. I'm not as bad a troll as I come across.
That's what social media should be for, though. Damn it.
I agree.
We love you for it.
Yeah, keep taking troll.
Are you not entertained?
That's exactly right. Everybody just needs to take themselves a little less seriously. But seriously, thank you for your work. Thank you for educating us. Thank you for sitting down with us. And do you have any other ways of people to interact with you? If you have any more questions or want some access to your research?
Yeah, check out Tim Hewitt, PhD on YouTube. I've got over 400 videos up on there. And drop me a line on the twit. I'm happy to give you my opinion.
Beautiful.
For what it's worth.
All right, guys, keep working on the sensory function of your patients, especially post-ACL, and don't forget about that opposite leg.
Yep.
Beautiful. All right. Have a good day, guys. Good luck with patients. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.